countries are also struggling with the so-called second wave. So I think we're going to need to stay abreast of this because it's going to be with us a while longer. So what I'll do in this talk is I will discuss the impact of COVID on pituitary tumor care in general, and then as it pertains to endonasal surgery in particular. So first thing I think is very important to note is that the syndrome may be completely asymptomatic. In fact, there are a lot of people that are walking around, normal people, healthy people, asymptomatic, that don't know that they're carrying the virus and are spreading the virus. And this becomes a big problem, particularly for vulnerable populations who do not know them or may not know that they're close to somebody who has the virus. The typical syndrome, the full syndrome that is recognizable is like a flu-like syndrome with features of fever, cough, feeling on being unwell, shortness of breath if it proceeds to a pneumonia. Early symptoms such as a nose smear and ageusia, lack of the sense of smell and taste, are also common because it's a respiratory virus and it affects the nasal passages, the respiratory epithelium. And there's some evidence that corona may even gain access to the intracranial space through the olfactory tracts. And there's also evidence that it's a neurotropic virus. In other words, it loves to creep into the nervous system along the nerves. In the full-blown syndrome, patients may proceed to an ARDS, a severe pneumonia, acute respiratory distress syndrome, sometimes necessitating supplemental oxygen or ventilation or ECMO. And this can then proceed to a multi-organ failure, septic shock, widespread thrombosis, and a severe immune response, and ultimately, unfortunately, death, particularly in patients who are vulnerable. Now, as best we can tell, from the time of exposure to the time of onset can range between 2 days and 2 weeks, which is the reason behind why if a patient or person is deemed to be exposed, that they quarantine for at least 14 days, particularly if they've been into areas of high transmission, or they've been in contact with an individual who's known to be COVID positive. It's best to stay away for at least 14 days so that if you're going to develop symptoms, the majority will develop symptoms in that time frame. What is still unknown is whether or not people remain able to spread the virus long after 14 days. There's some evidence that some people continue to spread the virus for months and months. And this is a dangerous situation because obviously if we don't know when people stop spreading the virus, it becomes much more difficult to practice isolation and tracing. Person-to-person spread is by close contact. It's believed to be by droplets. Best evidence is that at least 6 feet or 2 meters of space between person to person is optimal, and coughing, sneezing, talking, that sort of thing, it alone can also lead to spread by droplets. If someone has contaminated a surface and then you touch that surface and then touch your face, that can lead to transmission as well. And therefore, cleansing of surfaces with disinfectants that contain the appropriate ingredients to limit transmission are very, very important. And of course, frequent hand washing. And the wearing of face masks is very, very important in protecting the environment against someone who may have the virus in their nasal passages. Rapid diagnosis by RT-PCR using a nasopharyngeal swab. There are also antibody tests available. The question is, what is the true positive and the true negative of the antibody test? That is still being worked out at large by the infectious disease community. The best way to deal with COVID is prevention. And that's the reason why in most countries where the outbreak took place, they went into lockdown to reduce the risk of transmission. And this, of course, has severe economic consequences. But as we've seen in places like Europe, in places like Asia, who took the steps, we have seen that those transmission curves have reduced considerably. And some countries who still have not reduced that curve because they haven't applied those stringent precautions continue to have high rates or even increasing rates of transmission. Avoidance of crowds, which is why we're not having meetings as we used to. A lot of our medical meetings have been canceled or postponed, and we're doing those meetings by webinars like this one, typically to reduce the likelihood of transmission and keeping our social distancing from our colleagues. Most places are now canceled any non-essential travel. And even Europe, I believe, is going to open to travel starting July the 1st, and maybe some other countries will also open. The standard methods of prevention we've gone over: washing your hands with soap and water regularly. As surgeons, that's uneasy for us because we're so used to washing our hands many, many times during the day. So it's nothing new for neurosurgeons or any surgeons. Sanitizers that have at least 60% alcohol or some bleach. That's also very good to limit the transmission. And we talked about touching the face and nose and covering your face with the face masks. Now, let's get into specifics about pituitary tumors and COVID. Nothing is different from the standpoint of the fact that pituitary tumors require multidisciplinary care. It's not just the surgeons, it's the surgeons, the endocrinologists, the neuro-ophthalmologists, and so on and so forth. So we continue to pursue a multidisciplinary approach to the care of patients, even during the era of COVID, and more particularly because we're going to need to decide who needs treatment and what kind of treatment. So to stratify patient risk, monitoring and delivery of timely care requires that multidisciplinary input. We have learned that we have to limit outpatient attendance, and therefore telemedicine has become very, very important all across the world in terms of delivering care to patients and avoiding direct contact with patients. And telemedicine has been shown to be effective in terms of evaluating patients and providing them good counseling during this period of time. As a matter of general note, pituitary tumors per se themselves do not affect the immune system, except in specific cases, which we'll go into in a minute. And we know that the immune system is very important from the standpoint of infectious disease. However, pituitary tumors, particularly the functional category, are extraordinarily important in terms of increasing the amount of comorbidities. For example, we know that for COVID patients, the kinds of comorbidities that can severely affect the course of the disease include things such as diabetes, hypertension, obesity, asthma, and cardiovascular disease. And we know that specific pituitary syndromes such as Cushing's can affect diabetes and are associated with hypertension and obesity, truncal obesity, weight gain. Acromegaly also is associated with diabetes and insulin intolerance, as well as hypertension and cerebrovascular and cardiovascular disease. So these functional pituitary tumors can themselves lead to the comorbidities, which in fact make the morbidity and mortality of COVID much higher. So now we go into specific pituitary syndromes. First of all, let me address the issue of Cushing's and adrenal insufficiency. Both Cushing's and adrenal insufficiency present significant higher risk in cases of COVID. Adrenal insufficiency increases the risk of contracting COVID and a higher risk of complications. In fact, if a patient is infected, there's a very strong risk of that patient being triggered into adrenal crisis. So such patients need obviously close surveillance and management to prevent that. Cushing's itself, because of hypercortisolism, leads to immune suppression and therefore higher risk of infections such as pneumocystis, pneumonia, and this itself can significantly alter the course of COVID infections. Therefore, patients with adrenal insufficiency must be counseled and instructed to continue taking their medications as prescribed. And if they develop symptoms, they need to increase that dose, such as they normally would do for sick days. And they must always maintain supplies for steroids, either oral or injectable. And those patients must be instructed to wear medical alert bracelets so that if they have to go into the emergency room, they have that information available for the treating physicians in the emergency room. During this period of COVID, we have to be careful about some issues regarding the diagnostic workup for Cushing's. One of the things that we depend on in evaluating patients for possible Cushing's is measurement of what's called the salivary cortisol. Typically, it's done at midnight. Typically, we get 2 consecutive levels of salivary cortisol at midnight, basically to document the lack of diurnal variation with Cushing's. However, this collecting the saliva and getting it to the right place for analysis can increase the risk of transmission of COVID infection and also exposure of the laboratory staff to potential droplets. One of the things that is also very important in the evaluation of Cushing's during this period is, although we know that Cushing's, 80% or more of Cushing's is due to pituitary tumor, but there's also the possibility of adrenal tumors or lung tumors that could be the culprit. So unlike in normal times, we are advised that patients who are suspected of Cushing's get a CAT scan of the thorax and abdomen and pelvis as soon as possible to rule out the presence of other tumors, so that if they do have those tumors, they can go to treatment. During this time period also, we prefer that patients who are suspected of Cushing's syndrome be put on medicine as soon as possible, pending when it is safe to proceed with surgery. And that medication of choice would be the steroid inhibitors. The indications for surgery for Cushing's would be those patients who have clear evidence of biochemical activity that's severe and that they remain hypercortisolemic despite the use of steroid inhibitors, or they're using steroid inhibitors and they have severe medical side effects, in which case those patients should then have COVID testing. And if they're negative, they can then proceed with surgery using personal protective equipment by an experienced pituitary surgeon. And if, of course, they are positive, then more stringent levels of personal protective equipment need to be undertaken by the surgical team. That's the main indication for surgery for Cushing's in this COVID pandemic. Now, how about other treatments, other tumors such as prolactinomas, growth hormone tumors, and non-functional tumors? What is the care of those patients? For patients who've been diagnosed with mild acromegaly, have a clear pituitary adenoma, but no visual compromise, no mass effect, and they're not in any significant medical danger, those patients can be deferred for further evaluation and management for a couple of months until the transmission rate in that particular environment reduces to a safe level to warrant proceeding with continued evaluation or treatment. In patients who have severe biochemical activity or severe medical symptoms, hypertension, diabetes, obstructive sleep apnea, and so forth, but don't have a mass that's large enough to cause visual deterioration or compression of the anterior visual pathways, those patients should be treated with somatostatin receptor treatment drugs or growth hormone receptor drugs such as pegvisomab or somatostatin receptor ligands. In the case of microprolactinomas or even the macroprolactinomas that have no visual compromise, clearly those patients should be treated with first-line dopamine agonist treatment. And as you know, those are very effective in over 70% of cases. In the patients who have macroprolactinomas and visual deterioration, whilst they can be put on dopamine agonist treatment, they need to be monitored closely to make sure that the visual deterioration does not progress whilst they're on the dopamine agonist treatment, because visual deterioration would be an indication for surgical decompression in these cases. In the case of non-functioning tumors, non-functioning pituitary adenomas that are discovered, say, incidentally, have no mass effect, no visual symptoms, those patients can be monitored with visual fields and visual acuity. And only if vision deteriorates would they be candidates for surgery. All other patients that are being followed, that are in remission and are all well controlled on medicine, can be monitored by the pituitary team using telemedicine. We have suspended treatment of radiosurgery and radiotherapy for the next few months. We're not doing that just yet. And just as a means of reducing transmission. These are benign tumors, and there's no reason that a few months will alter the course of disease. So we're holding off on that. We're obtaining imaging as needed if we need to, but we're being very careful not to overly use that because of reducing the risk of transmission. There's a special case for the patients with electrolyte disturbances, patients with diabetes insipidus and or hyponatremia. As you know, one of the most common electrolyte abnormalities in the first week or two after pituitary surgery is hyponatremia. And it's very important to monitor these, particularly during the age of COVID, for patients who have diabetes insipidus, also need to be monitored because of the potential loss of fluids as a result of fever or tachypnea if they develop COVID symptoms. Because of the limited accessibility of blood testing during this period, we advise patients that that they should delay the desmopressin doses to allow for diuresis so that they do not become hyponatremic. Hypernatremia is a potential respiratory complication of COVID because of the, again, the water loss as a result of the respiratory infection and so on. In patients with severe COVID and DI, they may need to be on desmopressin. There is some evidence also that COVID leads to hypercoagulability and venous thrombosis and pulmonary embolism. Therefore, dehydration must be avoided in patients with diabetes insipidus because that can lead to hypernatremia, hypercoagulability, and the likelihood of thrombosis. If necessary, patients need to be on subacute heparin in addition to careful monitoring of input and output as well as the electrolytes. Now, for patients who have been evaluated and are told that they need surgery, but they're waiting for surgery, obviously it becomes a problem for some patients because they're worried, stressed out, and not sure whether or not they should go ahead and if so, when. We advise those patients to stay in close contact with their surgeon and endocrinologist by telemedicine. Patients should be counseled about the natural history of pituitary adenomas. We know that macroadenomas at best progress at the rate of about 1 millimeter a year. Microadenomas is about 0.4 millimeters a year in terms of natural history progression. So the risk over the next few months is very, very small. And in the case of functional tumors, we have some temporary treatments for patients with Cushing's, acromegaly, and of course, prolactinomas. So patients should be counseled that even though they may be postponed in terms of the actual surgery and the definitive treatment, that there are some reasonable options for those patients, and that by staying in touch with their physicians, nothing terrible is going to happen to them. For those that have visual compromise, as we talked about, those patients need to be monitored with visual fields and visual acuity and instructed to report any acute visual symptoms. In patients who have to go into the hospital, they should be advised that most hospitals across the world have some patients with COVID in the hospital, but most places usually isolate those COVID patients so that the other patients who come into the hospital are not exposed. Patients should also be advised that resources are stretched thin in many hospitals, particularly in things like specialties like anesthesia, because of the need for frequent intubation for patients admitted with COVID. So patients should be advised that these resources may be limited. Most hospitals require testing before admitting any patient, and that should also be told to the patient. And even where they have to come into the hospital for surgery, they're not allowed to bring with them visitors. In our hospital, we still don't allow visitors except in extreme circumstances. So patients should be advised that if they have to come in for surgery, they may have to not do so without their families with them. And they should also be advised that given the situation in most hospitals, that surgery could still be canceled even when it was scheduled. Most places have reduced elective activities. We did the same thing with our hospital. We're just opening things up and trying to increase capacity gradually. We still have very stringent infection prevention measures to minimize the spread. Everyone is required to wear masks and use personal protective equipment. patients coming into the hospital must be screened, temperature, questions about travel, and that sort of thing is very important to, again, limit the spread. The hospitals must have specific teams for looking after the COVID patients and specific areas for COVID patients admitted into the hospital. In the ORs, most ORs have modified their ventilation parameters to allow for frequent air exchange, frequent cleaning and disinfectant of different surfaces. For endonasal transphenoidal surgery, there's been a significant backlog of patients across the world. In our facility, we had a backlog was over a month of surgeries that we had to cancel. And so now that the hospital is opening back up, we need to re-triage those patients, because some of the patients who were non-urgent become semi-urgent, and some of those even become urgent. And so you have to go back. We've gone back through our surgical list to determine who we need to do first and who we need to do next. We're only performing surgeries, obviously, that cannot be delayed. Any surgery that has an alternative in terms of other treatments, we will continue to wait until it's safe to proceed. Now, if the surgery is deemed to be necessary and to go ahead, the patients must be taken through the screening steps to make sure that it is safe for them to come into the hospital. All patients must be tested for COVID 48 hours prior to surgery. And if the patient is positive, then we consider deferring the surgery until the patient is cleared. However, if it is not possible to defer because there's acute visual loss or severe medical disease that can only be addressed surgically, then the surgery will proceed with the appropriate personal protective equipment for the surgical team and the appropriate treatment and care in the operating room, anesthesia, the surfaces, air exchanges, and so on. We know that the endonasal procedures are extraordinarily high risk, both to the patient and the providers. In fact, if you recall, some of the earliest cases out of China that had significant transmission were from endonasal transphenoidal surgery. And so it presents a very high risk to patients. We advise surgeons not to use microdebriders and drills to the extent possible. Only use it as minimally as you can. If you have to use it for as short a time as a period as you need to use it during the procedure. There have been some devices now that have been used to protect against the droplet aerosolization. Some of these have been very useful in limiting the droplet spread intraoperatively. We still use the same intranasal preparation that we've always used, and that's a matter of, I believe, surgical preference. There's a big question still as to what you do when you have a CSF leak in a patient that has undergone transphenoidal surgery. If there's a risk of COVID spread. We know that there's a potential spread into the intracranial space through the olfactory system. Obviously, the CSF leak needs to be repaired, but the question is what kind of surveillance needs to be undertaken after that patient is discharged home because of the risk, potential risk of COVID in the environment. So I think that is still an open question. We advise the patients to stay in touch with us and report very quickly if there's any question or symptoms in the case of patients who had CSF leaks at surgery. When they return to the clinic, we don't use sprays or anesthetic sprays or decongestants when they go back into the clinic for their endoscopic evaluation in the ENT clinic 2 weeks after surgery. Rather than that, we use pledgets as needed. And then if we, to the extent that we can avoid doing endoscopy in the post-op period, we try to do that. But patients sometimes will need that to debride the area. So we have to do that again as carefully as possible. So those are the comments that I had. This is an ongoing issue. We've learned a lot, obviously, in the last several months. We continue to learn more as we go along, and we'll have to see how things evolve. So with that, I thank you very much. We're happy to take any questions.
Yeah, thank you very much, Nelson. I may start with the first small comment. So we have actually stopped completely our outpatients department especially for pituitary patients. So we better keep them a couple of days longer in the hospital to avoid any hyponatremia, any SI-ADH syndrome, or we can at least recognize it early enough and treat it while they are still in the hospital under COVID, let's say, negative circumstances. But we don't see them at our outpatients department physically at all. Yeah. So there's, for example, no post-op endoscopy at the moment.
Right.
Mainly because our ENT people, they just don't do any endonasal endoscopy in these times. Yeah.
Right.
And it works quite well, especially if you do some nasal packing post-op, you kind of avoid, it's not as comfortable, but you can avoid the one and the other scarring. Yeah. So is this okay? Do we have any questions from the audience?
Stefan, I have a question. Sorry, I was 5 minutes late joining in. Hi, there was a problem with Wi-Fi. Nelson, great talk. Thank you. Enjoyed that. What I wanted to ask, basically, for the initial first 2 months, when the workload, we saw the COVID going up and up, we stopped doing all kind of endoscopic surgeries. But for last 1 month, we have been doing those that we can, who were in trouble and we couldn't avoid surgeries. But every time we have done surgery, we're using the usual PPEs, the usual N99 masks. But on top of it, besides that, what we have done is we've used a plastic sheet, a cover, just like what you have for your intubation, you know, the glass box that we have, a plastic box that you have. So exactly the same thing, the plastic cover that you put on microscope, we made it custom made for ourselves. So, you know, 2 hands can go in, we have all the equipment inside, and we have the assistant and the scrub nurse also with their hands inside. And we have done cases nearly every week since we started doing them. And we have operated on a COVID positive patient as well. But obviously we have been very, 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 very careful, and there was no way we could avoid it there. But generally speaking, if at all possible, we'd avoid. On top of it, obviously, as you know, these patients have higher risk of pneumonia following surgery as well, and anesthesia. So, you know, as long as you can make sure that your patients are aware of it, yes, there are ways of going around it, but these are difficult ways, and it's difficult time. The best thing is to avoid surgery at this time, if at all possible, if you're worried.
Good points. Yeah.
One question which has come up, and I also wanted to ask that, is how frequently do you do COVID testing before you will take a patient for surgery? We are doing 2 tests a week apart before we take the patient to theater. Is that something which you follow, or it's not?
Yeah, if the surgery's within 48 hours, Chandra, we do that just the 1 test. If the patient is more than 48 hours, we do the first test, and then they have to do another test. Particularly if they go home, let's say they're seen on, or they're at home, and we cannot control exposure. If they're in the hospital and the COVID test is done, even if it's after 48 hours, we know the environment in which they are, we can skip the second COVID test.
So if you are scheduled somebody for, say, 10 days later, would you ask them to quarantine themselves?
If they're in the hospital or they're going home?
If they're going home?
Yes, they must quarantine themselves. Yeah.
I think those are guidelines from Stanford. Stanford people, when they came up with this idea, their guidelines were that you should have 2 negative COVID tests and at least 2 to 4 days apart, if at all possible. Because, you know, the COVID usually comes positive around 4th to 5th day of being exposed. And the highest chance of getting is between that 5th and 10th day that you'll pick it up. So their idea was to do that. And as Nelson said, quarantine and isolation is essential during this time if you're going to send the patient home. And even if you have operated and you send the patient home, again, they need to be in isolation as well, because if they develop a problem, then their pneumonia, etc. problems would go up as well. So those are the recommendations.
Okay, I think we do it much easier. We do 1 test on admission to the hospital if they are symptom-free, yeah? And this is usually 12 to 24 hours before surgery. Just on a day of admission, 1 test and then immediately surgery next day, yeah?
Right. Yeah,
We do the same. In Germany, we do the same. Nelson, have you knowledge of any surgeon who got infected by an endonasal surgery?
Yeah, there were some reports from China, Henry.
Yes, I know, but I mean in the US.
I haven't heard anybody yet.
Yeah.
I have not heard anybody yet.
You know the famous case from Wuhan in which they said 14 people got infected from a pituitary case?
Yeah.
That gentleman wrote that case up and said that, no, this is not true. All those people who were infected, none of them were from theater. They were from either recovery or ward. So those people who had no gear in the ward and outside, they got COVID positive, and none of the people who were wearing gear in theater got infected.
All right, good. Sebastian? You must unmute yourself. Sebastian, we cannot hear you. You must unmute you.
Let me
by yourself. It's not working?
Yeah.
Who can unmute you?
Let me just check.
I tried to do it, but I cannot find him. Where is he?
No, yeah, I've got it unmuted now. Sebastian, are you there?
You can hear me? Yes?
Yes, we can.
Yes, now.
Yeah, just one comment about this and the test before. During the crisis, I mean the difficult part of the crisis, we were doing a test a week before on the test the day of admission. I have the feeling that one important thing is not necessarily a risk for us. The risk is in case of a major surgery in a patient who get infected the week before. Mm-hmm. And we had a few patients that required ICU because of COVID. The few days after the surgery, in my memory, we had 2 or 3 patients like this who had a bad time after the surgery because of being contaminated. There is a report now from China about major surgery, grade 3 and 4, I think, and it was a 20% rate of mortality in case the patient get infected. So I don't know if pituitary, a simple pituitary goes into this category of major, but if you do a skull-based cases, for example, in a patient who is already a little bit weak, you know, is 50, 60, has comorbidities, yes, I think we put those patients at very high risk, and testing him one additional time is not too much. And we ask during the bad period, I was talking to the patient and telling them, stay home, isolated, be careful with your relatives, and all of this.
Mm-hmm.
Yeah.
So I think in my opinion, it was more to lock down all the pituitary cases because of security for the surgeons, not for the patients really. Yeah. So because we were all the ENT people were afraid they may get infected from the aerosol that's produced by endoscopy. Yeah, but it wasn't really so much that the surgery was so difficult that it may pose a hazard to the patient. Yeah. So, okay. Do we have any further questions?
Does anybody have any experience? I have a question. Does anybody have any experience, Stefan, with this? What to do in a case where you have a CSF leak and you, at surgery, maybe you did a craniopharyngeal, not a subtle leak, a real leak, like maybe a craniopharyngioma, you did an extended approach or something, or intraventricular tumor that went in from the cellar into the ventricle. You clearly had a leak, high flow leak. You repaired it with a nasoseptal flap or whatever technique you like. What's your level of concern in sending that patient back to the community? They tested negative before you did the surgery, okay? Then they did the surgery, then had the leak. Now they're going back to their home, you know, just regular community at home. What's your level of concern, knowing fully well that now this patient is not just at risk for infection, but now at risk for infection in the setting of a CSF leak that may still be not completely, you see. So do you keep your patients longer in the hospital? Do you monitor them in some way, retest them? What do you do?
That's a very good point, Nelson. But you know, especially in Europe, we're keeping patients longer in the hospital, typically longer in the hospital than in the United States. So, and during the COVID times, we had actually reduced our patient population to nearly half. Yeah, so we had always positions free here to keep the patients longer. And my personal experience is very small. We only did very, very few extended approaches because we tried to avoid all endonasal approaches, just in case of really massive visual disturbance. But in those cases where we had to repair, we kept the patient maybe for a week, maybe even 8 days, until we were completely sure this was sealed. And I mean, you know, it is very rare that it reopens after day 8. Yeah, so if you have solved the problem in the first week, I think it's done. What's your experience in the?
I don't know that's one thing I'm struggling with. Is what I'm doing right now is doing what something similar to what you're saying, is keeping them maybe 2-3 days longer than I normally would. I don't know that is the answer, but I do that just to make myself feel maybe less anxious.
I can't recall many patients who were readmitted after a week. Don't you think? I mean, it's very rare. It's usually in the first days. If it
it's usually in the first days.
Yeah, I think the recommendation during pandemic is that you should send the patient back to their family if they are able to take care of it and are sensible. And if they can isolate themselves, they should not stay in hospital. In India, many people were sued after many doctors were sued because they admitted a patient and it was COVID positive afterwards, and the relative thought that it was because of the admission in the hospital, and they got it from the hospital. So hospitals are not a safe place at the moment. So no. I think the recommendation is, if at all possible, I would send my patients home in 48 hours, and I would make sure their family is aware of that and they understand it fully, and that's probably the safest way of doing things. And you keep in touch. The good thing is that telemedicine is so good now that we are able to do lots of things through it, and the quality is pretty good at the moment.
Yeah. Okay.
All right. So
that was brilliant. I think Stefan,
shall we move on?
Would you like to introduce our next speaker, please? Yes, I think
Henry.
And we can have discussion afterwards that as well.
Yeah. Henry is the next speaker, is it correct?
No, we have Sebastian to go.
Sebastian, welcome. Okay, Sebastian, it's an honor for me to introduce you. Sebastian from Fröhlich from Hospital Lavoisier in Paris, a very experienced skull-base surgeon, a very good friend. I'm very happy to hear you talking about your surgical strategies for skull-base chordomas and your experience. Thank you very much.
Thank you very much. Thank you very much, all. It's really nice to be with you guys. So I have to share
just share the slide. And Nelson, if you wouldn't mind, If you could answer the questions that are there on the chat.
Okay. Do you see me? It's okay?
Yeah, perfect.
Okay. So my topic is surgical strategy for skull-based chordoma. We have a significant number of chordoma in my department. All this was initiated by Bernard Georges. He's at the origin of this experience with chordoma that he started many years ago. Chordoma is a challenging tumor for skull-based surgeon, as you all know. And why is it so? It's because it's an infiltrative tumor and it can extend in different areas of the skull base. You see this case, it's in both petrous apex with a little bit of intradural extension with the risk of CSF leak. It goes down, the same case, between dura and the bone behind lateral mass of C1 along the endotoid process and also in the soft tissue prevertebral space. If you look down in the same patient, there is tumors behind C2, and there is even tumors in the foramen between C2 and C3. So this is a classic example. It's not all of them like this, but it's a classic example of this challenging tumors that can spread in different areas of the skull base. There is different types of chordoma. This one was a case with extremely rapid growth. You see that after my surgery, resection was not complete, but it was not bad. And in fact, before starting proton beam therapy, 2.5 months after the tumor was back, this patient survived around 2 years. Proton beam therapy was definitely more efficient than my surgery. This was another case, extremely slow growing tumor seen in office by Bernard Georges 20 or 30 years before for a 6-nerve paresis. He was lost in follow-up. He refused surgery for a small tumor, and he came back to me in office with this huge tumor. So he was free of any symptoms with this chordoma for about 25 years. I did surgery in this patient. He was 70 years old when I did it, with the objective of keeping him intact, avoiding CSF leak. I left a piece of tumor, but I am following it without proton beam, and it's not growing until now. So the growth rate before surgery is extremely important in chordoma. I think it's underestimated. We just submit a paper on this. It's a very important piece of information to know what kind of tumor you have in front of you. So I advise you to look at this, because until now, there is not so much ways to differentiate those different types of chordoma. If we look at some of our results, you see on those 167 skull base and craniocervical junction, a characteristic of our patient is that most of them had a surgery before, and they are being referred to us after a recurrence or after an incomplete resection. Most of our patients, if they have not been radiated before, are radiated after surgery. And in the vast majority of cases, it's with proton or mixed of proton and photon, depending on the situation. Follow-up, progression-free survival, overall survival is similar to other series in the literature. What's important for today is to understand that the extent of resection remains a very important prognosis factor in chordoma, and it should be the goal of surgery, obviously considering also the quality of life after the surgery. Extended endonasal, it's logical, it makes sense for a chordoma that is a midline tumor. So it was a major change in the surgery for chordoma. And before, it was huge skull-based approach to reach the clivus. With endoscopic technique, we made significant progress, I believe. So our series with endoscopic endonasal approach, it stopped in January 2016. We have done much more since then, but we were quite dogmatic at that time with endoscopic endonasal approach, pushing the agenda of the endoscopic endonasal approach quite far. In some cases, for big craniocervical junction, we did 2 stages surgery for those big, huge tumors. Most of our patients were operated before, which makes the surgery even more difficult. reconstruction can become very challenging if there is no more nasoseptal flap. And if radiation therapy was done before, if we are facing a recurrence, it's even more difficult because the scarring process is not so easy. And you can see here that depending on the fact that the patient had a treatment before or not, your possibility to achieve a complete resection is not the same. If it was a primary surgery, we were able to achieve a complete resection in 74%. If not, it was only 32%. What about CSF leak in this series? Our rate of CSF leak is not so good because we have 18% of CSF leak. It's similar to the big teams that are doing a lot of chordoma in this region. I'm talking about clival lesions, and in Pittsburgh, they have about the same rate. This is to say that for those clival tumors, craniocervical junction tumor going intradurally, the issue of CSF leak is definitely not solved. This is a case of craniocervical junction chordoma, very extensive tumor going in both condyle, going into the jugular foramen with a little bit of intradural extension here. We did this case endoscopically. It was a nice case. We were happy at the end of the surgery. It was a very long surgery, but we made it. You see that there is a lot of resection of soft tissue to get to the tumor, drill the condyle, identify hypoglossal canal, very deep. It's 12 centimeters. I have to say that I still remember this case because it was an exhausting case and quite painful, to tell you the truth. But it was good for us, but not as good as for us, for the patient, because the morbidity of those cases is significant. And it's only the beginning for this patient because a few days after he had to go over another surgery for fixation. There is drawbacks with endoscopic endonasal, especially in major cases. I'm not talking of a pituitary case. There is endonasal morbidity because we resect a lot of soft tissue. There is velopharyngeal insufficiency when you take out some big tumor at the craniocervical junction. You have mastication difficulties whenever you go laterally in the pterygoid muscles or others. And you have hearing issue whenever you play around the Eustachian tube, you decrease the hearing. So extended endoscopic endonasal approach is great, but when you go laterally, when you go deep, when you go intradural, you increase the risk and the effect of this surgery on the patient. It may be worth the price for a complex tumor such as chordoma, but I believe we have to think of other options, less aggressive options. So how could we reduce the morbidity? One way is to make endonasal approach less aggressive, trying to preserve tissues to come back to the true meaning of endoscopy, which means going deep with an endoscope and then you increase the corridor, not starting at the nostril. How could we improve the dural closure? Approach selection. Maybe we should not be so dogmatic with endoscopic endonasal for big tumors, and maybe the use of microscope, endoscope, two-stage surgery could be an option. So over the years, we came to a kind of a different approach with endoscopic endonasal. We try to be one nostril. I am using this chopsticks technique, which means I hold the endoscope on a suction, my label rotative suction in the same hand with another instrument in the right hand. I can only do that if my endoscope is supported by the endonasal structure. My holder, it's a middle turbinate, inferior turbinate. If the corridor is very narrow, with this rotation of the suction, I can be quite precise. So this is an example of it. It's a clival chordoma. You see how we hold the instruments. This suction, in fact, I don't control it because there is only one place it can go. The corridor is very narrow, so it cannot escape me. The control of this instrument is quite easy because of the narrow corridor. And you can do also some quite difficult and precise things with this technique because you have a quite good control of the instruments. Here also, we are not dogmatic. It works in some cases. In some others, you need more space. But I think it's a way to reduce the morbidity of the approach. In a case like this, for example, one nostril contralateral approach, we used angle instruments. 30-degree scope, 45-degree scope, 70-degree scope, and you can see that you can have a look behind the carotid artery, behind the petrous segment of the ICA, taking this part of the tumor on the other side without a need for an extensive transpterygoid approach, for example. We could reach here the area of the jugular foramen. Dural closure, I have tried everything. In fact, I don't think there is one technique I didn't try, and I was frustrated with all of them. Stitching was my last adventure with trying to close. It's extremely painful, and I don't feel that, in fact, it gives better results. I had some leakage, even with something that looked quite nice at the end of the surgery, but the patient leaked. So there is definitely some factors that we are not taking into account with this issue of closure. And I am now using this technique from Naples, from Capabianca and Cavallo experience, using only fat and focusing more on intracranial pressure, keeping the patient 45 degrees for 2 weeks, avoiding supine position as much as possible, sometimes putting a lumbar drain with a shunt on the lumbar drain like Chin is doing in Tokyo. And with this technique until now, I have not done hundreds of cases. Obviously, Luigi has more experience than I am, but I have the feeling it could be a good option. Tumor bed coverage is also important. It's not only a question of closing the dura. In a tumor like this, if you're resected, you have to put something because you will have both ICA exposed, parapharyngeal ICA, you will have the dura exposed. So you have to cover all those tissues. We had one case in the past of bilateral arteritis, carotid arteritis. Patient died because of infection, because it was not properly covered. So we described a few years ago this flap, a huge flap that take also the floor of the nasal fossa on the lateral wall of the nasal cavity to have really a big surface of mucosa to cover those huge tumors that are operated with the endoscope. Approach selection is definitely important in those tumors, and being too dogmatic, I think, with endoscopic endonasal approach may make you doing some mistake because you are going too far with an approach that is not necessarily the best approach for the specific case. So this was a chordoma, mainly extradural. There is almost nothing intradural, maybe here a little piece. So this tumor, definitely endoscopic endonasal approach is nice because you are very rapidly on it. There is two ways of doing it: by nostril, posterior ethmoidectomy on both sides. You prepare a nasoseptal flap, maybe two nasoseptal flap to cover. You will take out the tumor, but the morbidity for this young patient may be significant, at least in the next 6 months to 1 year, and she may keep some issues because of the approach, like loss of smell. So this is typically a case where we try to apply this one nostril chopsticks technique. We just make an incision in the rostrum mucosa, pharyngeal mucosa. We take out the mucosa of the sphenoid sinus. We drill the clivus with fungal instruments, with fungal endoscope. And at the end of the surgery, we close by putting a big piece of fat in the sphenoid sinus and tumor bed cavity. And we suture the mucosa of the rostrum of the sphenoid, just like we would suture the skin when we do a transcranial approach. We forgot that mucosa is skin, and skin, if you close it, it's a good way to avoid a leak in transcranial surgery. So here you can see that with those angle instruments, we can go quite far, up to the level of the jugular foramen, behind the carotid artery. Resection is nice. Risk of CSF leak is low in this case because there was only a little piece of intradural extension. We full file the cavity with fat, and then we suture at the end. She didn't leak, hopefully, but you see that the morbidity of this strategy, I think, is not bad, and the patient was happy without significant issues because of a major endonasal surgery. sorry. Yes. So this is another case of clival chordoma, a complex one. We thought that it would be easy, that it would be easily sucked away from the vessel and from the brainstem. If you look on diffusion MRI, in fact, this tumor is maybe quite fibrous. And now we are very sensitive with diffusion MRI to try to predict the consistency of those tumors. So here we were very surprised of this consistency. It was fibrous. It was extremely painful to take away from the brainstem and to take away from the perforators. So it's not because it's a chordoma, it's not because it's hyper T2, it's not because it doesn't look adherent to brainstem of perforators that it will be easy. Here it was a nightmare. Hopefully patient went well, but it can be extremely challenging even if the tumor is midline, even if it looks like a nice clival chordoma. Every perforator in this case had to be dissected away from the tumor with scissors, with sharp dissection. We closed this case using the Napoli technique with a big piece of fat. I am not to the point where I don't use the nasoseptal flap. I'm not confident enough. I know that Luigi is not using the flap anymore in some cases, but this patient was fine and she didn't leak. This is a case of a brainstem chordoma infiltrating the brainstem. What is the goal in a surgery like this? The goal is not to achieve a complete resection. It's not possible. It's infiltrating the brainstem, and there is no way a complete resection can be done. Endoscopic endonasal approach in this condition is nice, following the tumor into the brainstem. It was a very nice, nice case. We resect quite easily everything that was extradural. And then, because of most of those chordoma extend intradurally this way, following a little hole sometimes in the clival dura, we just followed the tumor intradurally through this little hole that was 5-6 millimeter wide. There is no need in a case like this to make a wide resection of the clival dura. The wider is the resection, the most difficult it will be to close. And you can do that if you plan to achieve a complete resection, but in a case like this, it doesn't make sense anyway. So sucking the tumor from the brainstem was enough. We had this little opening to close, and the patient did not leak postoperatively. This is another case purely intradural. It's quite unusual for chordoma, but I have few cases like this. We hardly could identify the origin of this chordoma, and this patient was obese. So endoscopic, we could do the job, but the issue with this patient is not taking out the tumor endoscopically. The issue is to close, because she is obese, and we know that the rate of CSF leak can be much higher in obese patients. It's also going a little bit laterally, as you can see on the side, and you sometimes are not very comfortable with endoscopic endonasal approach, especially if you don't want to open too wide to try to avoid CSF leak. So in this case, we choose a combined petrosal approach, classic combined petrosal with transposition of the sinus. It's quite nice because we could dissect all the cranial nerve from the tumor. We could peel the tumor from the brainstem. I believe that going endoscopic endonasal, sometimes you don't necessarily push as far as you would have pushed the resection along the cranial nerve, along the brainstem, because you don't have the same precision with your movement with the endoscope compared to a microscopic approach. So the resection here was complete, and she did not leak. Avoiding a CSF leak with a combine is much easier than avoiding a CSF leak with a wide opening of the clevis through the nose. I will skip this case because I'm running a little bit late. This was a combination of endoscopic and open. Recurrent chordoma are sometimes extremely challenging. This patient had 3 surgeries before 2011, 2013, 2014, radiation therapy. I decided to go after this patient, this chordoma, because it was a slow growing tumor, even after radiation. Some chordoma, when they recur very fast. And the question we should ask ourselves is it worth it doing a surgery? Sometimes not. But because the biology of this tumor was still a slow growing tumor, I decided to resect this tumor. It's going into the peduncle here. There is tumor in the clivus, but it's going quite lateral. I was not feeling confident going endoscopic endonasal. So the same here, we did a combination of transcranial approach, anterior petrosal approach to get to this lateral aspect of the tumor. In fact, there was some infiltration of the nerve. You will see it here. There is infiltration of the root of the 5th nerve. So here also, I was happy to come under with a microscope. There was adherences to the cranial nerve because of previous surgery. And there was this last final piece very high on the peduncle, close to the exit zone of 3rd that I could not reach. So we did a transsylvian approach to have a better access on the origin of 3rd. And with the combination of those 2 approaches on endoscope, we were able to reach this piece of tumor. Well, it's a quite unusual case, quite extreme. It's not the videos that you are doing every day, obviously, but combination of endoscopic, of microscopic, of different corridor, at the end, we could achieve a quite good resection of this chordoma, especially the part of the chordoma that was going into the brainstem. It's the most important part, in fact, to resect. If you resect only the part in the prepontine cistern, you did nothing. I finish with this final case because it was a combination of two strategies, endonasal and microscopic. It was a young lady. We did it, in fact, just before the COVID. It was a big tumor spreading everywhere in the basal cistern, but with a significant part in the cavernous sinus here, for example. So we decided to resect everything that was red with an endonasal approach, everything that was intradurally with a transcranial approach. She was almost asymptomatic. So you always have to balance the risk of the surgery with the symptoms of the patient. And it was also a slow growing tumor because she did an MRI. She's a doctor, and she did an MRI for a study 5-6 years before, and the tumor was already there. It was a functional MRI for a protocol. And you can see here the resection of the tumor inside the cavernous sinus, classic endoscopic endonasal approach. The goal here was to stop at the level of the dura. We didn't want it to create a leak, because if you create a leak, then you need to keep going. You cannot stop once you have a leak, because closing an incompletely resected tumor that is leaking during the surgery, the risk of leakage is extremely high. So we focus on trying to avoid a leak. Closure, we did it like the same patient before, suturing the mucosa. And for the part of the tumor that remained, we did it after the COVID because we could not do it during the COVID period. And we took out this remaining part of the tumor, big part, going up to the peduncle, down to the almost to the foramen magnum. We did also a combined petrosal. We changed our strategies. We are working on this technique now. We call it a mini combine because it's a smaller incision. It's a cosmetic mastoidectomy, and it's an anterior petrosectomy from behind, not from subtemporal. And we did it for this type of tumor because we knew that it's a soft tumor to resect once the dura is open. So this is the case with the mastoidectomy, identifying the facial nerve here, shaving the labyrinth, and the anterior petrosal approach from behind. Classic technique. And once we are intradurally, then you're happy because with this wide corridor, multiple angle, multiple line of sight, you can really dissect the tumor away from each cranial nerve, from the vessels, and you can achieve a complete resection, because this lady is young, and what she needs above everything is a complete resection to have proper proton beam therapy and to have the best possible prognosis. So here is a resection controlling the cranial nerve, one after the other. I don't think I would have achieved, it was quite adherent to the brainstem, as you can see here. If I would have come endoscopic on the nasal, most likely I would have left a little layer of capsule of the tumor over the brainstem. So this is the mammillary body from below, classic corridor of the posterior petrosal approach. Closure is quite easy with fat, reconstruction of the bone as usual. So I go now to my conclusion. Chordoma is extremely rare. In France, it's in the skull base, it's between 20 and 30 cases. In Europe, I don't know, but it must be probably around 150. Henry will confirm. I think we need for this type of tumor, because it's rare, because it requires specific strategy, we need referral centers. We are communicating now in a way that we can have for very specific tumor places where all the techniques are managed, endoscopic, open, mini, whatever, that could give the best solution for patient. Surgery is not the treatment by itself. We hope, we need alternative treatment, targeted therapy. Research is extremely important for tumor like this. Thanks to my team, thanks to my fellows, research fellow, who did a great job to prepare cases, videos, and a lot of this. Thank you very much.
Yeah, thank you, Sebastian. Thank you very much for sharing your amazing experience with us. Yeah, definitely. And I think the most important takeaway message is, first of all, to have a tailored approach with every technique we have available for every individual patient. And then, of course, I took from your lecture that still the CSF leak is a major issue in these cases. And I know it, of course, from personal experience as well. Honestly, I think that we have improved a lot, not only with the nasoseptal flap, but also with the part of the Naples recipe, that we have the patient get up very, very early after surgery, and not have him supine in bed for a week like we did before with the lumbar drainage. We don't do this anymore. And since we use nasoseptal flap and lift him up on the next day immediately, never have him supine, it's, I think, gotten much better. Is this also your experience, isn't it?
Yes, it is. It is. For the Kleinwald tumors, the big one, I think it's the most difficult to close. It's nothing to compare with transtuberculum for craniopharyngeal, for example. In the clivus or craniocervical junction, from the beginning, the risk is higher. But I really liked this technique from Naples, from Matsuro Chin in Tokyo, because both focus on the key factors that push the CSF out, which is intracranial pressure. We were using lumbar drain before, but now when we put a lumbar drain, we put a shunt on the lumbar drain, which allow a much better control of the CSF outflow in the drain. Patient can stand up. I mean, it was very clever, but it's almost the same than Napoli technique with the patient that really stand up rapidly, in fact, to lower quite naturally this intracranial pressure.
Yes, I think that's very important. Yeah.
Sebastian, there is a question from Zhao Peng from China, and he's asking that, how do you suture the mucosa? What technique do you use? Do you use two hands to stitch, or is there any special instruments that you have to stitch the mucosa back?
I would say for me, it's very painful. For him, it's very easy, I'm quite sure. I am not skilled like he is. But he has much more cases than I have. But yes, it's 45 minutes, 1 hour sometimes. We use a classic forceps. I don't like the clamp forceps, because the clamp forceps, in fact, you don't want to hold the needle too strongly. the needle will go where it has to go, in fact. If you try to control the needle strongly, in my hands at least, it's more difficult. We do the nodes outside, 1, 2, 3 different direction, and we close. Like this, you don't have to push this node down every time. But I know that Zhao has good technique, good experience with this, much better than mine.
So I have one question from the audience, which I had myself. So Sebastian, when do you indicate proton beam irradiation? In all patients dogmatically, or only if you see a remnant on postoperative imaging?
No, proton beam, we do it each time. And I think we still should do it. I stopped doing it each time for chondrosarcoma, but for chordoma, I do it each time.
If you are convinced you have reached a complete resection.
Yeah, absolutely.
And when do you do it? Before you see on MRI where a remnant may be?
I do it up front. The only situation where I did not do it is in elderly patient. This patient I showed you, 70 years old. I know that the tumor is very slow growing. So in this case, you can avoid it. But in a medium age patient, yes, we have, and it's recommendation from the chordoma community. I think chordoma has a much worse behavior than chondrosarcoma. We all know that, except lateral chondrosarcoma in the petrous bone. Most of them have a much better behavior than chordoma. Chordoma, you need to hit the tumor hard with surgery and proton beam therapy up front. And with this, I have to say we have quite good long-term control.
Okay.
Sebastian, there's a question again regarding the lumbar shunt that you're talking about. So somebody is saying, why put in a shunt when you can get away with a drain, which is temporary, and you can take it out on follow-up?
The shunt, well, maybe I explained, I didn't explain the proper way. The shunt, we don't put it in the patient. We put the valve system along the lumbar drain.
So basically,
it's a kind of valve on the lumbar drain to control the outflow, not a shunt in the brain.
Do you mean a gravity valve or a shunt valve?
A shunt valve. There is a specific one in Japan that is made for that, but we don't have it in France. So I use the Sofisa valve, and I put it along the how do you call this?
The line.
The line. I put it along the line, and you can control the out pressure, and it makes it easier for the patient to walk around, and it's also easier to manage for the nurses because you have this security against over drainage. It's more natural.
Okay, brilliant. I think we're going to go to Henry for the cases, and then we can have more discussion afterwards. Sebastian, you can have a look on the chat. If there are any questions, you can answer directly to them as well.
Okay.
Yeah. So
Henry doesn't need any introduction. Our IFNE president. Yeah. Again, thanks for organizing this, Salman. Thanks for inviting me.
No. We are not yet done. Hang on. Let's have the cases from Henry.
No, I know.
Yeah.
I have a question to Sebastian about the radiation. Is there any proof that the proton beam is better than other types of radiation? I know there's a study underway in Heidelberg about carbon ions. I don't know. I have one patient who he refused the radiation because he has to care for his ill wife, and he had to travel to Heidelberg. He said, no, I don't go that way. And it's now 8 years ago, and he has no recurrence. Other patients which I sent for proton beam or for carbon ion, they came with a recurrence already. So I think the tumors are different, as you said. Some are slow growing, some are fast growing. But is there any proof that radiation is
in my opinion, there is proof. I mean, if your question is there a randomized trial comparing techniques? No, because most of the chordoma until now have been treated with proton beam, and they have been treated with proton beam because it's a radio-resistant tumor. So comparing radiosurgery, fractionated IMRT with proton beam, you need a center with a big number of patients to be able to conclude. So I think not doing proton beam therapy now, I think is a little bit risky. I definitely agree that we need prognosis factor prior treatment, and we still don't have it. That's why growth rate before surgery is something easy that everyone can do, calculating the volume, and it gives you some information. With prognosis factor, maybe we could identify tumors that would not require proton beam therapy upfront. But until we have those criteria, I think it's risky not to do it. All the experts on chordoma, oncologists, vast majority of them have this feeling. And as a surgeon, I have to say that I also have this feeling. What can I say? Carbonion, between carbonion and proton beam, I don't know. I'm not expert enough to say which one is better, but between radiosurgery or IMRT and proton beam, if it was me, I prefer to have proton beam.
Yeah. All right. One last question about.
It doesn't mean that you cannot have a chordoma having proton beam with a recurrence 2 years after the surgery. I had cases like this, but some tumor behave very badly. And if you knew that before, maybe you would not have done surgery. In the case I showed, what was the mistake? To do surgery with a regrowth 3 months after, or doing proton beam? The mistake was to do surgery. I didn't bring anything to the patient. Proton beam therapy on this patient, the tumor disappeared and she survived for 2 years. But if I knew that before, I would have changed the strategy. I would have said for this tumor in the sphenoid sinus, let's go for proton beam upfront. No need for the difficult path through the surgery.
Yes, I agree. I think the chordoma is a heterogeneous group. It's the same like glioblastomas, where now we know they behave very differently, and it's the same for chordomas as well. All right, thank you, Sebastian, for this great talk, as usual. I just want to show 1 or 2 cases if we have time. This is one recent case, what I saw. This is a 47-year-old female. She had headache, was a little bit fatigued during the day, and had blurred vision. And then the visual examination showed a right visual acuity loss on the right eye, but no visual field deficit. And the chronological workup showed a partial pituitary insufficiency, and MRI showed that lesion. So my question to you and Nelson and all others is, what is it, and what would you do as a next step?
Meningioma.
Could be meningioma. Sebastian, you have to look. Stefan, Chandra?
I go for meningioma.
Chandra? Anybody from the audience wants to take it? Anybody wants to raise their hands and answer?
Could still be a pituitary adenoma. Prolactin levels?
Normal. Prolactin normal.
I would go maybe a little bit more towards pituitary adenomas and meningioma. Both possible, but
pituitary is low in the cellar, so I would go for meningioma.
All right. But you have no dura tail. That was my concern. No dura tail.
Not on the clivus.
What would you do as the next step? You suspect a meningioma, differential pituitary adenoma. So what is the next step to do? What approach? Or radiation, a biopsy?
Extended transsphenoidal.
Did you get the labs?
What? The lab?
You get the labs? Were the pituitary labs all okay?
No, there was a partial pituitary insufficiency.
Okay.
But no excess of hormones. Sebastian, anonasal, transcranial, eyebrow. You see there is no steep, tuberculum. What should we do?
If I go more towards pituitary adenoma, I would definitely go endoscopic endonasal, depending on looking at all the films. And I guess you have a better idea because you are You have seen all the films, the testing, and all of this. If it's melangioma, I go more transcranial, because the part in the cavernous sinus will not be resected anyway. But for pituitary adenoma, if it's soft, yes, you can resect a big part of it.
Yeah, I would go transsphenoidal because of the cavernous sinus involvement, which at least offers a possibility to remove it if at all possible. Yeah, and it's medial to the carotids, to the supraclinoid carotids.
Yeah, when I looked at it, there's a wide intercarotid distance, and there's infiltration of the cavernous sinus. And my suspicion was more to pituitary adenoma than meningioma, because there's no duratail, but of course, it's not always necessary. So we made an extended approach. You have seen there's a wide distance between the carotid from the left side to the right side. So we open the dura in the stellar space, and then we make an extension, a transtuberculum transplanum. We open it, and then we took some specimen, and then you see it looks like a typical adenoma. There's the arachnoid plane. We could dissect around. Then you see here, this is a stalk with a normal gland, yellow tissue, normal pituitary gland in this area. Then we have a 30-degree endoscope to look to the left side and to the right side, and then the frontal part is mobilized with different curettes. And we could remove. The tumor had a good plane to the frontal lobe in this area. And this is the final view. So we did not take a big effort to take it from the cavernous sinus on the right side, because it was not so easily done. This is a post-op MRI. You see our nasoseptal flap was okay. And then histology came back with Ki-67 40%. It was considered a high-risk adenoma, but non-functional adenoma. So what would you do with this patient then?
I think with this Ki-67 index, I would probably suggest radiation. Certainly.
We continue. Yes, we did an MRI after 6 weeks, and you see here there is a remnant of the tumor in the cavernous sinus on the right side. The stalk is good, the gland is good. So this was she was really doing well, but there was tumor in the cavernous sinus. So we sent her for fractionated stereotactic radiation therapy, 52 grays. And then after 9 months, she came back, and you see the tumor is really shrinking down. And it looked really good. The stalk was good, gland was good, and she does not need any hormonal replacement at that point. And she came back after 1.5 years. Everything looks good, no recurrence. And we were very happy. And then she came, what is this? I have a feel here. I don't have to close that. Okay, 1.5 years post-op. She has no symptoms. Ophthalmology was normal. Endocrinology was perfect. Then, unfortunately, she got diagnosed with breast cancer, and she was under chemotherapy. And then 4 months later, this year, she came back and had head and neck pain, neurological intact. And then she was sent for MRI imaging, and you see that. You see that there's a lesion. The good thing is it is not dark in T2, but it's bright. It's extending on the right side up to the brainstem and the lower cranial nerves. On the left side, it is more in the cervical spine area. So what do you think? Nelson, what kind of lesion is it?
Wow, this is very interesting. I would, with the history of the breast cancer, that's one suspicion. Could it be a MET? That would be one suspicion I would have because of the progression, the rapid progression and the history of a recent breast cancer. That would be up on top of my list. I don't think it's the tumor from the pituitary. It looks remote, it's not contiguous. So although the Chi-67 was high, but I doubt it very strongly, and she was in control. And then the third possibility is that it may be completely unrelated, and it may be a new lesion, maybe a meningioma in this area. I don't think it looks like a chordoma. So those would be my choices.
Yeah. Sebastian, Stefan?
It's a carcinoid pituitary, no?
Yeah, Ki-67 of 40 is very unusual and close to carcinoma already, isn't it?
Very high. It's a classic features of carcinoid. Huh?
Yeah.
We've met.
It's not a meningioma? No meningioma?
No.
More like a seedling. It looks in the whole thing looks in a subarachnoid plane.
Yeah. Okay, what should we do?
And get it out.
Take it out.
Which approach?
Was it there on the earlier scans which were done post-op? Did we cover the CV junction area at that time?
It was overlooked.
Okay.
It was overlooked by the radiologist and was overlooked by me as well, because you look here to the gland, but you don't look here.
Mm-hmm.
You see here is a small lesion, already 1.5 after years of the surgery, but it's growing in 1 year, amazingly.
But you have the diagnosis because you
No.
But the pathology of the first tumor was what?
Was a pituitary adenoma.
Yes, but with Ki-67 at 40, no, or something like this?
You slept, huh, Sebastian?
I don't think so. I don't think I slept. I saw 40.
More than 40. It's almost 60 or something.
Yes.
No, 40%.
40. Yeah. So I did not sleep.
Yeah, it was overlooked in this MRI. You see it already here, 1.5 year. But we looked, of course, we look here. Everything looks good, and even the radiologist is not reporting it because it's so minor. So what we do? What approach?
Familial carcinomatous syndrome. So may have something somewhere else as well.
No, there was nothing else. It was just this lesion, which was extending in this way area on the right and on the left. So Sebastian, which approach?
Which approach? I think I would do, most likely a posterolateral far lateral approach, I think.
Which side? Because you see here on the right side, you have to, you should come to the cranial part. On the left side, you come to the spinal part.
Well, the both side is for posterolateral, far lateral. No, I will still do that midline approach. With the hockey stick, maybe more on the right, but with the midline approach, you can reach both sides. You can go on the right side, and you can also go on the left side. So I would do that.
But if you come midline, it will be hard to look behind the spinal cord.
But you have quite a big window between the condyle here and the spinal cord. So I think this corridor here could be sufficient to work it out. And for the other side, maybe we need a little bit more of hockey stick on one side, counter incision down to the tip of the mastoid. I mean, I think it's feasible with this, but it was soft, no, on the first surgery.
Yes.
So the softness is something good for us.
Yeah,
if we
exactly.
make the corridor from the right side, probably it would give more space to go to the left. Can do it from one side, probably.
No, I think one side is difficult. So I did not, my consideration was the same what Sebastian told me. I was not sure what it is, but it's unlikely to be a meningioma. So if it is a adenoma, then it should be soft. And when you look to the T2, you see it's almost hyper intense. That means it should be soft. That's why my decision to make a midline approach, because I can take the tumor on the right, and if I'm lucky, I can also take the tumor on the left. That's why we made a midline approach. And you see here, this is the arachnoid intact, but here's already the tumor visible. So I was not sure from looking, is it meningioma or not? But then when we took the tumor, it was very soft. It respected the arachnoid plane, but it was encasing everything. And then when you take it out, you see it is typical like this adenoma. And then we sent it for histology, immediate histology, and they confirmed that it is an pituitary adenoma and not a meningioma.
Oh.
So at first we came from on the right side to remove the tumor which goes up. You see it's growing around all the cranial nerves, but there was a good plane. It was always a plane between the nerves, although it was encasing all the small lower cranial nerves and the hypoglossal nerves. But we could dissect it in this preserved plane so that all nerves could be preserved, and we got a good resection on the right side. And then there was some vessels coming from the base, which were coagulated on the dura. This is a hypoglossal. This is a vertebral artery running here. And then on the left side, we had only a little bit space between the cord and the dura and the lateral margin of the canal. But because the tumor was soft, we could debulk the tumor very nicely. And then we could resect it. But you see, it's not much space. If this would have been a hard tumor, I think I had to stop it and to come really from a lateral approach. But this was soft. And in between the small nerve rootlets, we could dissect the tumor. And then finally, there was a problem to look in front of the spinal cord, because not a lateral approach. Usually in foramen magnum tumors, I have a far lateral approach, but here you see I cannot look in front of the spinal cord. We took a 45-degree endoscope, and we found a small piece of tumor which was left really in the midline. And this was then taken out, and final endoscopic inspection shows that there's no remnant and a good resection of the tumor, and the pia was intact. And then histology. It was the first day after surgery, showing the good resection of the tumor. Patient was intact, no problems. And then it came back again with a TI 67-40%. And then per definition, if you have a metastasis of this pituitary adenoma, it should be called a pituitary carcinoma. So the next step, it should be, she should undergo radiation, or should we wait? Because it's such a big surgical field, they cannot irradiate everything. So I thought we make a control, and when we see there is a recurrent lesion, we make a focused radiation, because I think the field, the radiological field, is very large. What do you think? What would you add proton beam, for example, or what should we do?
I would consider chemo. Temodal works for those tumors.
Okay.
I think it can work, not always, but it can slow down. It's a very aggressive carcinoid. It's not so usual to have such a rapid growth of metastases, because usually it can grow over a long period of time. They can grow for many years, but this one is very bad. So chemo, I think, could be indicated.
Yes, but we should not forget she is under chemotherapy for the mamma carcinoma. So this thing occurred during chemotherapy of her breast cancer. That is what my concern is about chemo. But maybe it is better with Temodal. That's right.
Temodal works, not always.
Yeah.
But works.
Honestly, we have some temodal experience with pituitary adenomas, but they usually come back if you stop temodal. It's in fact, it's a lifelong treatment. Yeah, so I think it's not ideal.
Yeah, difficult.
I had one query that if we consider this to be more like a CSF seedling, then we should actually be offering a craniospinal radiation.
Yeah.
Like we do for any other tumor which spreads along the CSF.
Yeah, yeah. Well, of course, we send her for MRI of the whole spine to see is there something wrong or not.
And the
Okay,
CSF.
I think we run out of time. I think we stop after this one case. So this,
Yeah,
okay.
I think
we continue with the questions.
Yeah, we just go to our multiple choice questions, and can you unshare your screen so that Emad can show those multiple choice questions, please?
Yes.
Brilliant. Emad, could you please show multiple choice questions? And we have, is Nelson here? Nelson, if you could switch on your...
Can you hear me?
Yes, we can hear you. Brilliant. So these are, actually, these are Sebastian's questions. Sebastian?
Yes.
Yes, Emad, can you enlarge this, please? There are some people, just enlarge it a bit. Sebastian, you may have to take your multiple choice questions and see how many people answered it right. Can you enlarge this further, please? Enlarge. Thank you.
Me? No.
Yes, these are your questions.
Okay, what should I do?
If you want to read through them and see how many people answered what. Emad, can you move up a bit, please? Thank you.
So which are the most reliable prognosis factors following surgery of chordoma? Extent of resection, yes, definitely. History of previous chordoma treatment, it's also important. The recurrent chordoma don't go the same. It's prognosis is not the same. Histological and molecular markers, characteristic, yes, definitely. So I think the people responded well. Age, yes, some people consider age and even sex as important to consider. What I wanted to say with this question is that, yes, until we have good, efficient, predictive factors, we have to do with what we have, which means several pieces of information to have an idea of what we are facing before treatment.
Okay, second, go down.
What is the overall 5 years local recurrence rate after gross total resection followed by adjuvant radiation therapy for chordoma surgery? So the vast majority of people said 25%. Hold on a second.
Sorry, yeah.
31%. Slightly more than 50%. 50-75%. It's more than this. No, it's less than this, sorry. 10%. Okay. So yes, the answer is it's the local recurrence rate after gross total resection. In my opinion, it's around 40%, something like this. 75 is too much. Overall survival at 5 years is progression-free survival is between 50 and 60% in the literature. So yes, median survival for chordoma is around 7 years. Which of the following statements about radiological appearance of chordoma is false? Lytic lesion on CT associated with soft tissue mass and a mushroom appearance. Yes, it's quite typical. Intermediate signal on T1, high on T2, typical. After injection of gadolinium, intense enhancement? No. Most of the chordoma do not have a high contrast enhancement. If it's the case, it usually means that it will be more fibrous tumors. The softness can be evaluated by this, but also by diffusion. Main differential diagnosis include chondrosarcoma and metastasis. Yes, absolutely yes, chondrosarcoma. This is why brachyury should be tested in each cases in pathology, because it really is the factors to differentiate both tumors. What element may render an anterolateral approach for CVG chordoma? If it's going below C2, endoscopy will have difficulties to reach the lower aspect of the tumor. Bilateral extension in the craniocervical junction, every time tumors is going far laterally, I prefer to do an open approach because risk of CSF leak is high and control of the cranial nerve is more difficult. Vertebral artery encasement, that's the definition of anterolateral approach, is that you control the vertebral artery. Intradural extension at the level of the craniocervical junction, I have a tendency to use open approach in order to avoid the CSF leak rate, which at this level is significant, as well as the morbidity of the endonasal approach.
Okay, brilliant. Okay, if you go on to Nelson's responses. Okay, Nelson, you can take this away, please.
Sure. So treatment options for pituitary tumors during the COVID pandemic include option 1, in mild acromegaly without visual compromise, schedule immediate outpatient visit, MRI and OGTT. This would not be a good idea because the patient has mild disease, number 1. There's no need to rush. Secondly, an immediate outpatient visit will expose the patient and the practitioners to potential transmission from other sources. An MRI can wait and an OGTT can wait. So number 1 would not be the option. Second, if the patient has severe acromegaly with visual deterioration, without visual deterioration, without visual deterioration, there's no rush for surgery. So the option of treating surgically with endonasal endoscopic surgery is a little bit aggressive in that situation. So this would not be a good idea either. Patient with active acromegaly who's 6 months following surgery, stable residual disease, says refer for radiosurgery, no rush to do that. Again, that option would not be desirable. The best option is, in the case of severe acromegaly without visual deterioration, treat the patient medically with either somatostatin receptor ligands or pegvisomab. So the best option here is the 4th option, the green option, and that was the one that 43.3%. So that was a good performance from everybody. Next question. In preoperative preparation for transsphenoidal surgery during the COVID pandemic should include, first choice, patients should be tested for COVID 2 weeks prior to surgery. This is a little too far out. Ideally, you want it to be a little bit closer than 2 weeks because 2 weeks is a long period of time. They can still get exposed. If the patient is COVID positive, give broad spectrum antibiotic coverage and hydroxychloroquine. Well, first of all, obviously the antibiotics would not treat COVID since it's a viral infection, and hydroxychloroquine has been shown to be more harmful than useful. So this would not be a good choice either. Next choice, if surgery is an emergency for severe acute visual loss, use routine surgical mask and gown. Routine surgical mask will not protect against aerosol spread. You need at least an N95 mask and of course a gown. So that would be the wrong choice. The last option, due to false negatives for COVID-19, the surgical team should use personal protective equipment even when the patient tested negative. This is the best choice, and 50% of the respondents answered, so that is the correct performance. Excellent choice. Third question, in patients with Cushing's disease during the pandemic, okay, Cushing's disease. First option, salivary cortisol test should be obtained with care to prevent infection of laboratory staff. Okay, we talked about that. The risk of transmission with saliva, collecting saliva is high, particularly for the laboratory staff. So if you're going to obtain them, you need to obtain them with care. Second option, patient with severe Cushing syndrome should be treated with remdesivir to prevent pneumocystis. They definitely should be treated with something to prevent pneumocystis, but that something is not remdesivir. So that would not be a good choice. Next choice, patients with Cushing's despite steroid inhibitors. See here.
Can you please show on the yellow, Ahmad? Just take care, yeah?
Next, I can't see the question. Yeah.
Thank you.
Yes. Should be referred for radiosurgery in patients with Cushing's despite steroid inhibitors. So the short answer is no. Radiosurgery, as you know, takes a long time to have an effect. And so patients who have Cushing's persistent despite steroid inhibitors and are symptomatic should be considered more for surgery than radiosurgery. And then the last option, patients in surgical remission should discontinue hydrocortisone supplementation. That is not good because of the risk of immune suppression. That is not good because that would predispose the patient to potential hypocortisolemia, and that is a potential risk for adrenal crisis. And so that's not a good choice either. So the best choice is choice number one, salivary cortisol test should be obtained with care to prevent infection of laboratory staff. And 28.6% of the respondents got that right. So.
Okay, that's brilliant. Any questions, comments before we wrap up? Henry? Chandra?
No, I think excellent session and nice discussion.
I want to thank everybody of the participants for joining us again for our webinars. Special thanks goes, of course, to Sebastian and Nelson, our speakers, for the interesting talks. I think everybody learned a lot. Special thanks again also to Chandra as the WFNS Neuroendroscopy Committee Chair. We do these webinars together. And of course, our host, Salman, as usual, thank you for giving the setup that we can meet here. And I hope to see you in 14 days again with another topic. So thank you, everybody. And I wish you all a nice weekend. And
okay, just before we go, can we all switch on our videos, and we are going to have a group photograph. So everybody switch on their video, please. And Ahmad, can you take a group photograph for us, please? Ahmad, you there? Yes, thank you. And we all can smile, please.
Jeez. Oh, bleeding.
So after your pituitary, was it?
Thank you.
Okay, brilliant. Thank you, everybody. Just last comment from Sebastian and Nelson before we wrap up. Yes, Sebastian. Sebastian, you want to say something?
Yes, thank you very much. It was fantastic. It would be nice to have it every week. My wife may not agree, but I enjoyed it a lot. Seeing you all is very nice. We have not so much meetings now, no courses, so being back together is very nice. Thank you very much for the effort. Thank you very much for the invitation. It's nice to see all those faces in front of me. Thank you.
Brilliant. Nelson? Just unmute yourself, Nelson. Unmute, please, Nelson.
He cannot, yeah, no.
It was a great pleasure being with everyone. I enjoyed it tremendously, learned a lot. Everybody stay safe till we meet again in person. Bye-bye.